Welcome. We are really lucky because we have Congresswoman Miller Meeks, who, for some of you need to know, she's an ophthalmologist, and she's the member of the 1st District in Iowa. She's a champion of vision issues, and she's on the Vision Caucus. And she left a hearing to be with us for a few minutes because she's so supportive of what we're doing. Welcome and thank you.
I'm just going to say thank you all very much. I am a member on the Energy and Commerce Committee as well as the chair of the Health Subcommittee on the House Committee on Veterans Affairs. I'm a 24-year military veteran. Very proud to be an ophthalmologist. Was a nurse before I was an ophthalmologist, and was on faculty at the University of Michigan, the University of Iowa, so taught as well, and then director of the Department of Public Health. So was very instrumental in getting some of our preventative eye programs and eyesight programs on board. So just want to thank you for all you do, your support for research, the research that you do, and the cures that groups like this are going to be able to put forward, not only for Americans, but for people all around the world. So thank you all so much.
So welcome, and thank you for joining us. And I want to start by talking a little bit about who we are. BrightFocus Foundation funds the most promising, novel, and innovative research to defeat Alzheimer's, macular degeneration, and glaucoma. We also provide expert information and free resources to help those that are impacted and their families deal with these devastating diseases. Since our founding nearly 50 years ago, yay. 50 years milestone, we have invested nearly $300 million in research, grants around the globe, 6,000 scientists, and in 25 countries. And we still have a long way to go to defeat these and many other neurodegenerative diseases. As a global leader in eye and brain research, a key focus of ours is to fuel cross-disease discoveries that enable earlier detection, diagnosis, and ultimately more personalized treatments for the diseases with no cure. When BrightFocus chose our tagline, Cure in Mind, Cure in Sight, it was to shine a light on the connection with these age-related neurodegenerative disease conditions, which we all fear as we age. More about that shortly. Today, our theme is Health Equity Begins in the Lab. And what do we mean? We mean that when it comes to the clinical trials that are fundamentally essential to turning medical research into effective new treatments and cures for 300 million people worldwide affected by these diseases. Blacks and Hispanics, individuals, women, and many other under-resourced populations are systematically not represented. We mean that true health equity begins with righting this wrong. Is it really righting this wrong or just doing it right for science? Until we do, too many of tomorrow's medical milestones may leave millions behind, crippling progress to cure these diseases for all people and for good. To appreciate its importance, today's speakers will give you a deeper sense of the current pace, breadth, and yield of biomedical research into Alzheimer's, glaucoma, and macular degeneration, and stress how critical both adequate funding and clinical trial diversity are now to sustaining the acceleration of real scientific breakthroughs that benefit us all. With that, I am pleased to introduce Dr. Jerry Schellenberg, who will describe how a better understanding of genetics in Alzheimer's is the launching pad for health equity development in clinical research. Dr. Schellenberg is a professor in the Department of Pathology and Laboratory Medicine at the Perelman School of Medicine at the University of Pennsylvania, where he is co-head of the Penn Neurodegeneration Genomics Center, director of the Alzheimer's Disease Consortium, and co-director of the Genomics Center for Alzheimer's Disease. He is one of the instrumental founders of the International Genomics of Alzheimer's Disease Project, and he chairs that sequencing initiative. And of course, like many of the panelists, he is the recipient of numerous prestigious awards. We at BrightFocus have the good fortune of working closely with Dr. Schellenberg on our scientific review committee, and I can confidently say that no one has done more to give a greater and growing understanding of the connection between genomics and Alzheimer's, which is so essential to curing and treating the disease. Dr. Schellenberg, I think we have to wait a minute. Hello, I'd like to introduce you to Bill Johnson, who's very active in the Alzheimer's Caucus, and he serves on the House Energy Committee for a few words. Thank you so much for being with us.
Well, it's a pleasure to be here. I do serve on the House Energy and Commerce Committee, and I sit on the Health Subcommittee. I've been here. This is my 7th term. It's the first time that I did not ask to be on the Health Subcommittee because I thought it was a futile effort because they've never let me do it before. This time I didn't ask, and lo and behold, I get assigned to it. So I guess I need to figure out the code, you know. But I'm glad to be there because the issues of Alzheimer's and the patient, the families, the providers, so complex, so many issues. I know I was telling Tom Reed, when I was first elected, I had a former dentist and pilot, because I'm a general aviation private pilot myself, and I had a gentleman come into my office advocating, of course, for the issues around Alzheimer's treatment, research, and all of that. And he had lost his pilot certification because he was suffering from Alzheimer's. But you could not tell it at first when he first started coming to my office. And every year he would come back, and he lived in my district, so I would see him from time to time at a Bob Evans in New Philadelphia, Ohio. And I watched his disease progress until the day that he stopped coming by, and then I learned later that he had passed away. Look, my heart goes out to those that suffer with the disease. I'm not a physician. If I were, I'd be working really hard to try and find a cure that would stop this from in its tracks. But I know that you folks are working on that. So you've got my support, and I'm just honored to be a small part, a little bitty cog in the wheel to try and help move us down the road on this important issue. So thanks for letting me stop by.
So now let's continue with Dr. Jerry Schellenberg.
Thank you, Stacey. Just a few numbers about Alzheimer's disease to emphasize the impact. So every 65 seconds, somebody new is diagnosed with Alzheimer's disease. In 2022, the cost to our economy of treating people with Alzheimer's was $320 billion. And that doesn't include the $240 billion for unpaid care that families give. And by 2050, the cost will be $1 trillion per year. And everybody in 2050 that will be part of that is alive today. On a personal level, we just heard the congressman talk. As I was coming to this meeting on the elevator, there was a steel worker here to lobby Congress, and he asked me, "What do you do?" And I work on Alzheimer's. He says, "Oh, my grandmother died of Alzheimer's." So many, everybody I talk to knows somebody impacted by this. So there's a tremendous cost to our economy and a tremendous cost to people with Alzheimer's and the families that have to take care of them. We don't have a cure, but in the past year, there have been 2 years, there's been 2 treatments now that slow the progression of Alzheimer's. And this is big news. This is, a start that we've really been hoping for. And it not only slows the progression of the mental decline, but also helps people to do daily tasks that they need for living. That drug is based on a gene, the amyloid precursor protein, which was one of the genes that I and a number of people worked on early on, in part funded by BrightFocus, and that was some of the work that led that to the qualification as a good drug target. So that's emphasizes how transformation of our field has been and how rapid in the last couple of years. A few other things that BrightFocus has done. In 2020, they funded the first commercially available diagnostic test for Alzheimer's, and the diagnosis is extremely important. In 2021, they discovered that sleep deprivation is a risk factor and not just a consequence of Alzheimer's. And that fact followed up by the discovery that deep sleep helps your brain get rid of some of the toxic proteins that contribute to this disease. Now, this rate of transformation in clinical advances is important, but then we have to ask the question, will this only be applied to the European people that are mainly in the study, or can we extend this to people of other ancestries and ethnicities? So one of the emphasis of my work is on genomics. So to extend what we've learned in European Caucasians, we've set up an international collaboration consortium that Stacey referred to, and so we're looking at samples from around the world, and we found many genes that are associated with Alzheimer's, and that's increased our understanding of the risks and origins of Alzheimer's disease. Now we have a solid evidence that genetics factors influence risk and resilience, and often these genetics factors differ between different ancestries. ApoE was the strongest genetic risk factor, and it actually has a lower effect in African Americans compared to European Caucasians. In Asians, it has about a 10-fold higher risk, and so knowing that tells us there's different underlying biologies that we have to pay attention. So we want to understand this because we want to treat everybody in the U.S., and of course that'll translate out into the world. But that's very important. Right now, the National Institute of Aging, this is something I'm involved in, it has collected DNA from many different populations to do full genome sequencing so we can understand at a very fine scale difference. And the collection of DNA samples is in part from the US, Hispanic, African American, Asians, but also around the world. So we have collaborations in Germany, in Africa, Peru, across South America, across Africa, and across Asia, and our Asian studies start in the US, but also we have collaborations with Japan, Taiwan, and Korea, and we have a large study of subjects from India. So this is the beginning of trying to understand risk factors in different populations, but we know that that's just the beginning, and this is what Dr. Haller really meant by health equity begins in the lab. So by studying these different groups, we then can translate that into drug discoveries and clinical trials. Also, there's a well-known observation that about 2 to 3 times more women are affected by Alzheimer's disease. So this is another thing we have to understand, and your gender influences how the neuropathology influences the disease. So up to this point, I've been talking about groups of people. What we really want to do, and this comes for the plea for more funding, so what we really want to do, we want to understand on an individual level what this means to a person not just a group. And so we can tailor treatments to each person. And this is what is called precision medicine. We're not there yet, but that's what we're working for. We're at a exciting point, and really these drug trials that have been positive in the last 2 years have really transformed the field. And part of what that means is that when there were so many failures before, drug companies stopped pulling money out of research. And so now this stimulates drug companies to put money back in, and they have if we hit this bar, we can get a drug approved. So this is not the end game. So I have my wish list of what the end game should look like. Okay, we need an inexpensive diagnosis, and BrightFocus has funded part of the path to that. We need preventative medicines that can be given 10 to 20 years in advance of any symptoms. And to do that, they have to be safe and they have to be cheap. We need to know on an individual basis who will benefit from those treatments that we start to prevent Alzheimer's. And we need to know, so I was talking to somebody last night, and they say, what about the environment? And I said, well, it's genetics. Geneticists don't actually use the E word, partially because we're pretty good at finding genes. We're not really good at understanding the environment, and that's a big thing we need to know. So we need to study the biology and genetics of AD in different people with ethnicities and ancestries. We need clinical trials of all people. We need multiple therapies because not everyone will respond to the same drug. We need a better understanding of what causes Alzheimer's in each of the steps in the process, because each step is a potential intervention point. So I urge Congress to continue to commit funding and research in Alzheimer's, and everybody knows somebody with Alzheimer's, so it's a big problem, and we need to boldly tackle this disease to recognize its massive national and global economic impact. Thank you.
Thank you, Dr. Schellenberg. Now I'd like to introduce our next speaker. Dr. Deborah Tan is a nationally recognized educator and advocate for dementia education and caregiving. She's CEO of the brain health organization Reminiscent in Valdosta, Georgia, and the author of The Race of Dementia. Dr. Tan is working tirelessly to eradicate healthcare disparities as it relates to diagnosis rates, access to treatment, early treatment, quality care, clinical research, and trial participation rates. She is also a lecturer at the Georgia State University's Gerontology Department and serves on the clinical research team. Dr. Tan.
Thank you for that warm introduction, Stacey. I appreciate that. I would like to first say to my esteemed panelists and certainly to our guests in the audience, I bring you a warm welcome from South Georgia, rural South Georgia at that. So let's get down to business. Alzheimer's incidence varies significantly by race and certainly ethnicity. Nearly 19% of Black individuals and 14% of Hispanics age 65 and older have Alzheimer's as compared to my white brothers and sisters. Despite their higher rates of developing Alzheimer's, underrepresented groups are significantly less likely to be diagnosed with the condition. Bring this closer, is that better? I like closer, thank you. Lack of diagnoses means lack of treatment, but it also means, you guys, they are unlikely to enroll in an active clinical trial, which is very important. Let's talk a little bit about the barriers to Alzheimer's and related dementias as it relates to, again, clinical trials. Today, a number of groups are disproportionate risk of being uninsured, lacking access to care, and experiencing worse health outcomes striking people of color and low-income individuals. Blacks, Hispanic, and Native Americans are more likely to be uninsured relative to whites and those with higher incomes. Low income and people of color face A, increased barriers to accessing care, B, receive poorer quality of care, and C, ultimately experience inferior health outcomes. Why is it important to recognize these inequities? I'm hoping that's what you're asking yourself. It is important to recognize these health inequities because as the population becomes more diverse, with people of color projected to account for over half of the population by 2050, it is increasingly important to me that we address health disparities. Candidly speaking, no one should be denied the possibility to be healthy for belonging to a group that has historically been economically and certainly socially disadvantaged. Dr. Matthews, my colleague, will further unpack this topic. Methods towards inclusion, inclusionary efforts in clinical trials. Build trust. I love that word, trust. Before introduction of a clinical trial, you must build trust. I think he's going to take precedence in a few minutes. So I'm going to get a couple of more out before they introduce it. Establish awareness campaigns around community people. Educational workshops and presentations discussing dementia for sure. Ongoing promotions of brain health. We need to also train care professionals with cognitive instruments. Written materials need to reflect the dominant language of the community of which you are seeking. Support the work of other advocates addressing systemic racism for sure. Workforce development. Workforce development preparation is designed to care for racial and certainly ethnic diversity in the dementia space. The clinical architect must be brought to the community. Again, the architect of the clinical trial must be brought to the community. All right, we're not expecting them to come to the ivory tower. Re-examine clinical trial participant exclusion criteria. We need to re-examine that for sure. Becoming culturally competent. Person-centered care is mandatory. It's certainly not an option. And also I would like to say, maintain ongoing relationship with local, state, and national governmental leaders. And I think this is a good segue, is it not? Yes. Okay.
We're going to pause. There's more to come. We are fortunate to have Representative Gus Billarakis is here. He serves on the Energy and Commerce Health Subcommittee, and like many, he's taken time in between votes and hearings and conversations to join us for a few minutes, and we're grateful for your participation.
Thank you very much. I appreciate it very much. These issues are very important to my constituents, but also my family. We've been stricken by Alzheimer's. I have a Parkinson's bill to end Parkinson's right now going on, and we have a legislative hearing. I'm on the subcommittee on health under Energy and Commerce. So we have very important bills that we're trying to get reauthorized and put into. Some are, like the Parkinson's bill, will be hopefully passed and becomes law by the end of the year. And we modeled it after the bill to end Alzheimer's. And we made quite a bit of progress with Alzheimer's. But also, the macular degeneration is something actually I suffer from. I have the wet macular degeneration from pathological myopia. So I know how important, and of course the glaucoma is so very important. These are issues that I focus on. And I appreciate you having me here today. I get an opportunity to honorary host, but I'd love to stay longer and learn more, but we've got to pass some legislation. And that's what I try to work on is bills, consistent bills, consensus bills that aren't very partisan. And we build consensus. So in any case, thank you very much for being here, giving me the opportunity. I appreciate it, and this is wonderful. And hopefully, maybe I can send down a couple staffers, and they can learn a little more and pass that information on to me. Thank you very much. God bless you. Thank you.
As he leaves, I would be remiss if I didn't point out that we both share Greek ancestry. And part of that Greek ancestry is eye-related diseases, just to add to the other discussion that we had. So thank you so much for what you're doing.
And I tell you what, the Greeks are everywhere. Especially when there's good food.
Especially when there's good food. That's great. Thank you so much.
Okay. Yes, I like to continue. And I left with a very poignant point about the importance of congressional leaders, and we just heard from one. And so I don't want to insult your intelligence for sure, but I just wanted to share with you some of the bipartisan legislation that is out there. So let's tackle it a few minutes. There is and has been several bipartisan legislation that have served Alzheimer's and related dementias. And I, as probably as well as yourself, I'm thankful. I'm so thankful. And we need the continued support with legislation such as BOLD. I understand we're going to be BOLD today, which stands for building our largest dementia infrastructure. So that's some legislation that's out there right now, BOLD. Alzheimer's Caregiver Support Act, dire need of that for sure. Comprehensive care for Alzheimer's is certainly out there. It's an act as well. That's naming a few, but my favorite, you guys, is called the ENACT Act. It speaks volumes as it relates to my community work. The emphasis of ENACT, which stands for Neuroscience and Alzheimer's Clinical Trial Act, from my understanding is Senate Bill 1548 and House Bill 3085. It seeks, you guys, to increase representation in Alzheimer's clinical trials among traditionally underrepresented groups. This legislation would reduce the burden associated with participating in clinical trials by funding the NIA to build trust, I love that word, trust among untapped communities of color, by expanding research and increasing diversity in clinical trial staff. ENACT addressed funding Alzheimer's disease research centers and increasing the number of Alzheimer's clinical trials, such as in my community, the rural South. The last piece I want to share about ENACT that's floating around out there right now, ENACT requires grant recipients to use community-based engagement strategies in their outreach. And this is so poignant because this speaks to the work that BrightFocus and Reminiscent is doing in Valdosta. I'm going to hurry, I see someone. The Valdosta Project is what it's called. It exemplifies community-based engagements. The BrightFocus Foundation, in collaboration with Reminiscent, endorses the framework of inclusion in healthcare and clinical trials. We conduct this by planning. We do a lot of that, implementation, and certainly the execution of our beliefs around the people, as I stated in my methodology a couple of minutes ago. So I want to conclude my remarks with a quote from Dr. Cornel West, and it simply says this: "You can't lead the people if you don't love the people. You cannot save the people if you don't serve the people." Video, Julie.
Another pause, because we're so fortunate to have Representative Dan Mercer from Pennsylvania. We have our UPenn representative here, who's a world leading the world in genetics. So we're glad to have you here. And all right, so thank you.
Yes, absolutely. Well, thank you all. I hope I'm not interrupting, but I was asked by my very good friend Tom Reed to come in and say hello. He knows this subject matter is of great importance to me and to so many members of the U.S. House, and I'm sure the Senate, but we don't talk to them all that often. I'm on the Problem Solvers Caucus, as former Representative Tom Reed was the chairman of, and so we spend a lot of time on bipartisan issues. We have 29 Republicans, 29 Democrats, and frankly, it's the most useful 1 hour or 2 hours, it's usually 2 hours a week that I have here, because we work together and we truly try to find common ground. But related to Alzheimer's, I became very, very, very interested, certainly from some personal contacts of not necessarily family members, but some friends whose older relatives were inflicted. But my daughter, who's now a med student at George Washington, worked at Mount Sinai doing research. And she would tell me she was just so not just fascinated, but also motivated to help, to find some answers, to help people with the rehab, with the diagnosing, and with the medications, and one day a cure, right? Because we know that there's, sadly, a lot more of a population that will be inflicted here. And we my goodness, there's no better funding or return on investment than to help people live the quality of life that they deserve to. So you can count on me being part of your team, and I look forward to being very supportive. So thank you.
And now I'd like to shift a little bit toward the vision light. And as we turn to glaucoma, we are privileged to have in the audience today Dr. Michael Cass. Dr. Cass is a Bernard Becker Professor in Ophthalmology and Visual Science at Washington University School of Medicine. Among so many contributions, Dr. Cass conducted some of the earliest studies on effects of the eye, eventually leading to the development of effective pharmacologic treatments of glaucoma. His many accolades include the Lifetime Achievement Award from the American Academy of Ophthalmology and the President's Award from the American Glaucoma Society. Thank you so much for being here. Importantly, as both Dr. Gordon and Dr. Cass have shared, their working relationship has lasted longer than most marriages. They are icons in the field of glaucoma research and in vision research. Our panelist, his colleague, Dr. May Gordon, is professor of ophthalmology and visual sciences and Division of Biostatistics at the Washington U School. She also has some information about AI that you may want to ask her about later. Dr. Gordon's numerous contributions to eye research include development of new measures and protocols, such as the first photo documentation protocol of corneal scarring with high test, retest, and integrator reliability. What this means to the rest of us is we go to the eye doctor and get tested properly. She received the Couch Award from the American Academy of Optometry for this work, and her collaboration with Dr. Cass in the steering committee of ocular hypertension treatment study was the first to provide evidence of the safety and the efficacy of topical ocular hypertensive medication, AKA drops, to reducing the incidence of glaucoma in individuals with ocular hypertension. Dr. Gordon.
Thanks. Thank you so much, Stacey. And I have been privileged over more than 30.
Get closer.
I've been privileged to work with Dr. Cass and others in this country and internationally on the detection and prevention of glaucoma damage. So just to give you a little context about glaucoma, glaucoma affects more than 4 million people in the United States who are 40 years or older, which is 3 to 4% of the entire population. So 3 or 4 people out of every 100 have glaucoma or this condition. Glaucoma costs the U.S. economy over close to $3 billion a year, and in productivity costs and direct economic costs. While research breakthroughs are occurring this very moment, these include laying the first groundwork for non-invasive assessment of intraocular pressure, which is one of the main risk factors for glaucoma damage. New class of medications available for the first time in 2 decades are ROCK inhibitors, so this is very important progress. Recently, a BrightFocus funded study paved the way for restoration of vision loss due to glaucoma using cell replacement therapy. 2 years ago, BrightFocus funded researchers to develop a new wireless device to assist in the diagnosis of glaucoma. Thank you, BrightFocus. Furthermore, some new exciting findings are coming around having to do with genetic therapies to reprogram cells to replace the function of retinal cells. All that said, federal funding for glaucoma remains at a very low rate. It is 5% of what the economic burden of glaucoma is and constitutes about $150 million of the National Eye Institute portfolio. So it's a small section of the NIH research portfolio. We would like to see that increase. I have spent most of my career in glaucoma research, both clinical trials and observational studies. And I can assure you that in the past, minorities were severely underrepresented. When I did a literature search of about 20 trials in the 1990s and before to set up the glaucoma prevention trial that we conducted, there were fewer than a dozen minority individuals in those studies. Totally. Think of that. When glaucoma differentially affects African Americans at a higher rate and Asians and Hispanics, they were not represented in our clinical trials. Now, we have since spent maybe 2-3 decades to correct that. In our study, African Americans represented 25% of the total sample, and this gratefully is being corrected, but it's a key oversight that we're still in the process of learning more about the disease in minorities. An absolute key to glaucoma management is glaucoma prediction, prevention, and treatment. All of this requires an eye examination. So the prediction is assisted by a very precise statistical model that's easily implemented by your doctor, your eye doctor, an optometrist, or an ophthalmologist. And this prediction model is very precise, even out to 20 years. And in our 20-year study, we verified that this prediction model correctly classified people on an individual level, not by race, not by gender, but by the clinical risk factors that increase or decrease the chance of developing glaucoma. So that precision medicine can be estimated only if you'd have an eye examination. So the eye examination is critical to prediction. Secondly, prevention. The ocular hypertension treatment study clearly showed that you could prevent or delay the onset of glaucoma effectively and safely. But that requires what? An eye examination. You must get seen by an optometrist or an ophthalmologist, an eye care provider. Finally, progression. In order to treat and prevent glaucoma from getting worse, what do you need? You need an eye caregiver and an eye examination. Sadly, such screening is unavailable or significantly limited in our underrepresented populations. They're not only underrepresented in our clinics, but often underrepresented in our clinical studies. So therein lies the catch-22. No examination, no early diagnosis, no prediction, no treatment. And we are talking about a condition that differentially affects the underserved. So I call for a collective commitment to correct this catch-22 issue or crisis. We must catch the disease early to protect its victims, predict and prevent glaucoma damage. Thank you.
I'd like to ask the panelists if you could move the mic a lot closer, because there's parts of the room that are having trouble hearing us. So I think they want us right on top of this piece. Yes, and the echo with all the activity is making it a little more challenging. We'll do our best to speak louder. Thank you, Dr. Gordon. And both Dr. Gordon and Cass were the 2022 recipients of the Helen Keller Prize for Vision Research, and we look forward to celebrating all of you tonight at the 50th Anniversary Gala. Here to talk to us about age-related macular degeneration is Dr. Daisy Hsu, faculty member of Ophthalmology Department at Harvard Medical School. Dr. Hsu's research focuses on the mechanisms underlying age-related diseases. Her work investigates the roles of mitochondrial and metabolic dysfunction in retinal eye diseases such as AMD and others. Dr. Hsu's research has been recognized by several awards and grants, including an Early Investigator Award from BrightFocus. Dr. Hsu.
Thank you, Stacey. And it's an absolute honor to be here today to speak to you all about macular degeneration amongst the distinguished panelists and the attendees. So thank you for this opportunity. I'll start today by setting the stage for explaining what macular degeneration is. And the abbreviation we use is AMD for age-related macular degeneration. So it's a disease of the elderly population. And the unfortunate thing, it is a leading cause of irreversible blindness. And the key word here is irreversible. Whilst cataract is the leading cause of reversible blindness, AMD unfortunately leads to irreversible loss of vision, whereas cataract surgery can be easily corrected, cataracts can be easily corrected via surgery. AMD unfortunately has no cure for restoring the damage that has been done. So currently all the therapies are linked to being able to slow the progression of AMD, but what damage has been done cannot be restored. And AMD affects the macula, so that's why it's called macular degeneration. The macula is the central part of the retina, which is the back of the eye. That's responsible for converting all the visual signals that we see in the world and transmits that to the brain. And the important thing is it affects the central part of our vision, and that's the part of our vision we use every day to drive, to read, to look at our phones, to attend this congressional briefing, and to be able to see and experience the world, because we're so focused on our central vision. And people who suffer from AMD unfortunately have somewhat of a black spot in their central part of their vision. So it severely impacts the quality of their life. And because this is a disease of the elderly population, a lot of people who get diagnosed, it's quite devastating because they can't, for example, recognize faces. And for that, it's very devastating because some grandparents, for example, may not be able to see the faces of their grandchildren. And with our aging population and increasing longevity, the numbers for AMD are destined to rise. And so I'd like to highlight some important statistics about AMD. So firstly, AMD affects about 1 in every 3 Americans over the age of 75. And also, nearly 20 million adults in the US have some form of AMD. And in the US, the total annual economic cost of late-stage AMD is estimated to be almost $50 billion, with more than a quarter of that cost attributed to geographic atrophy, which is an advanced form of macular degeneration. But the good news is there has been a very rapid pace of discovery for treatments for AMD that have emerged in recent years. There's many advancements in this field. And in fact, a lot of the BrightFocus funded research has contributed to these amazing developments in treatments for AMD. So in the context of wet AMD, so as we heard, there are wet AMD forms. So there's the dry form of AMD and the wet form. And the wet form is characterized by the development of new blood vessels in the retina, which there shouldn't be new blood vessels there, but unfortunately, due to disease processes, these new blood vessels start to emerge. And the problem with these blood vessels is that they're extremely leaky and they can bleed very easily. And that hemorrhaging of those new blood vessels leads to that loss of vision. And fortunately, there is a treatment for the wet form of AMD, and that is in the form of anti-VEGF treatments. And BrightFocus work has led to the developments of this novel therapy, and it is the gold standard of treatment for patients with wet AMD. The important thing to note is it only slows or stops progression of AMD. It doesn't actually reverse any damage. And some patients are non-responders to anti-VEGF therapies. So unfortunately for that population, there still needs to be more research to understand why these patients don't respond to the anti-VEGF therapies that are available. And over time, there is also tolerance to the medication. So patients who are on anti-VEGF agents, they may develop a tolerance and they may not be responsive after years of treatment with anti-VEGF therapies. So many advances have occurred in the AMD space. There have been advances in gene editing technology that have led to improved study and treatment of age-related macular degeneration. And early-stage BrightFocus support has led to a very exciting patient-derived stem cell therapy last year. And the first treatment for geographic atrophy, which is a dry form of AMD, was approved this February. And that has laid the groundwork for the discovery of the complement pathway in AMD, which is a very important part of the inflammation pathway that leads to the disease of AMD in the dry form. And so this is really exciting, and there are several other treatments in clinical trials. My research is focused more on the preclinical studies, and that involves looking at cell culture and animal models to understand the disease mechanisms and test novel therapies that could be then translated into clinical trials. So notwithstanding this fast and rapid pace of discovery, we do also need to know that federal funding is essential for providing the funding to enable this rapid pace of discovery. And the lack thereof in the increases in the federal funding is an important call to action. According to the NIH listing for the health research funding by category, the funding for macular degeneration unfortunately fell almost 20%, from a peak of $124 million in 2019 to $100 million in 2022. So this is a condition that affects 1 in 3 seniors over 75. And note that during that same period, the total NIH clinical research funding actually rose by 16%. So that's not matched in what is observed in the funding that is delivered to macular degeneration research. And importantly, another compounding factor is the reduced purchasing power of the funds due to inflation, and also the accelerating costs of research. The consumables and all the supplies, those costs are increasing. However, the purchasing power of the money that we are receiving from the NIH isn't matched to enable us to buy things at the same costs as we previously did. So there is a lot of groundbreaking research. There's a rapid pace of that discovery, and so that's really promising, but clearly there needs to be more work done to fund the AMD research and to fight and to cure this disease. Thank you.
Thank you, Dr. Xu. As I mentioned earlier, there is a meaningful correlation and connection between neurodegenerative conditions of the brain and eye. And here to speak with us about that is Dr. Preeti Subramanian, who is our Director of Vision Research at BrightFocus and responsible for the macular degeneration and glaucoma programs. Her background includes more than 10 years as a research scientist at NIH's National Eye Institute, and she holds several patents. Dr. Subramanian.
Thank you, Stacey. It's an honor to be here today at the briefing with distinguished panelists and everyone in the audience. As Stacey mentioned, the eye is an extension of the brain, and they are connected by the optic nerve, which is a bundle of nerves at the back of the eye that communicates the visual information to the brain. And so in Alzheimer's disease, age-related macular degeneration, and glaucoma, all of these are neurodegenerative diseases. And what that means is that as the disease progresses, there is a loss of, there's damage that can cause eventual loss of the nerve cells and the function of the nerve cells that can lead to loss of central vision or side vision, as seen in age-related macular degeneration or glaucoma, or loss of nerve cells in the brain that can that's indicative of early Alzheimer's disease or other forms of dementia. There are several scientific studies that have shown that Alzheimer's patients may have a thinning of the retinal nerve fiber layer and retinal ganglion cells, which are hallmarks seen in glaucoma. And so it's not surprising to see the similarities, given that the eye and the brain are connected. But the eye has an unique opportunity where it can be imaged or pictured using a non-invasive direct imaging technology to look at the nerves and the blood vessels in the eye. And the health of these blood vessels and the nerves can be indicative of the changes that are happening in the brain. So one example is a study that BrightFocus funded recently to look at the blood flow and the vessel density in the eye, and what they found is that the changes may be an early indicator of the problem with the blood circulation in the brain, which can indicate the risk of cognitive decline from Alzheimer's or other forms of dementia. So This application can have scope beyond Alzheimer's with other conditions like cardiovascular disease, Parkinson's disease, multiple sclerosis. So it's a very powerful diagnostic technology, but the application is not just for diagnostic purpose. There is a lot of commonality between these neurodegenerative diseases for risk factors and causes. And one of the things is aging, which is common for all three of the neurodegenerative diseases that we fund at BrightFocus. So as early as in 2003, BrightFocus funded research to look at optical testing methods that can be used, has potential use for diagnosis of Alzheimer's. And more recently, we have BrightFocus funded studies that have developed artificial intelligence model that may one day predict Alzheimer's disease by looking at retinal images. These are photographs that are taken during routine examinations, routine eye examinations. So definitely there is the diagnostic potential of using the eye. And with that, I want to also mention that there are reviews that are published in literature where eyesight problems, people with eyesight problems were 60% more likely to have cognitive impairment and 106% more likely to have dementia compared to those with no vision issues. And vision impairment has documented association with as many as 100,000 cases of dementia in the US. Yet, there are several studies suggesting that people of color are less likely to have their eyesight routinely examined than their white counterparts. And this could be due to the pervasive racial and economic inequalities, such as lack of insurance, lack of access to healthcare, and a general distrust of medical procedure. And we heard and saw the video of Waldasta that Dr. Tan presented earlier. So one obvious yet often overlooked takeaway is getting an eye exam that Dr. May Gordon emphasized on, since a lot of the eye examination is not just about getting prescription for eyeglasses. There's a lot more to it, and that's the only way to detect and prevent vision loss that can lead to blindness. So early detection and prevention that Dr. Gordon mentioned. And also to maximize the public health value of the eye-brain connection in the future with all these diagnostics that may one day be able to predict brain diseases using eye as a window. So more and more frequent, accessible, and affordable eye exams are a must for all of us. And thank you.
Thank you. To put clinical trial equity in a broader context is our next speaker, BrightFocus Foundation board member, Dr. Tanya Matthews. Dr. Matthews is the CEO of the International African American Museum in Charleston, South Carolina, opening to the world in just a few days, and a thought leader and a thought leader in institutionalized equity and inclusion frameworks, social entrepreneurship, and the intersectionality of formal and informal education. And I'd like to note that Dr. Matthews received her PhD in biomedical engineering and also spent time working at the FDA. Dr. Matthews.
Thank you. But I wear glasses, that's why I'm here, 7 days ahead of opening. So I would like to thank CEO Haller and Dr. Schellenberg, Dr. Tan, Dr. Gordon, Dr. Shu, Dr. Subramanian. This has been a lot, right? Taking all of this in, and part of what I'm closing out to do is help bring us back to this theme that ties it all together, this idea that health equity begins in the lab. The clinical developments and the tidbits and the facts that we have listened to today are not about incremental progress. We're talking about transformative breakthroughs that are imminent and that are happening even as we speak. Now imagine with me just for a second, based on the statistics and the numbers that we've heard, I can pretty much say that we can all imagine someone in our life, someone that we love or that we care about, that is affected in some way by any one of the three supposedly incurable diseases that we have just talked about, right? So imagine that person, put them in your head, in your heart. Now imagine that a therapy, a medication comes onto the market and your loved one can run and get it because it was designed for them. It was tested on folks who looked just like them, and therefore they can have access because that's where we are. It is now that personal. Now imagine same loved one, same therapy on the market is going to try to get that medication and is told, we're sorry. This is not available for you yet because we didn't test it on anyone that looks like you, that has your background. You can try it, but we're not really sure how it's going to work for you. Or even imagine that this loved one dies without being able to remember your name or see your face one last time simply because they never got the proper diagnosis and were never pointed in the direction of the therapy that could have changed their life. Now that ping that you're feeling, that is your superpower in this conversation. It's called empathy. And when we think about the way that medicine is going and what is possible, this becomes really important in the conversations that we're talking about when we talk about health equity, when we talk about access and inclusion. Empathy, that's the first part of this. So let me ping your second superpower, which is curiosity. Best factoid of today. White patients still make up 92% of clinical trial participants, 92%. And in the last 4 years, we've actually started to go backwards a little bit. As for example, African American participation has dropped by nearly 50%. Now, I know that I'm on the home team when I'm having these conversations, but as both a historian and a scientist, what I can tell you that we're not just talking about including more diverse populations in our clinical trial for the sake of including more diverse populations in our clinical trial. When our clinical trial participants are different and diverse, it motivates the questions that we ask. The questions that we ask and the research challenges that we take on in and of themselves also become more diverse, more creative, because we have a broader pool of people. That is how we get to innovation. But in addition to that, as we've talked about this advancing of personalized medicine, of our understanding of the different variations in prevalence of genetic markers across various populations, this is why we also need diverse clinical trial participants and diverse folks in our research, because we're taking good guesses, but we scientists, we're open-minded. So we're always looking for the question we never knew to ask. And in order to do that, we need the full breadth of genetic markers inside all of these trials that we're doing for things that come up as anomalies are actually roads to the cures and to the innovations and the path that we need. So this is why diversity within our clinical trials is actually about curing the broader population of all of these things that ail us, not just being in service to particular populations. So as I think about this, and I think about the museum that we're building, the International African American Museum has a genealogy and ancestry center built into it. And one of the top questions that we get is, can you help me understand this whole genetic testing of ancestry thing that we do? When that becomes one of the top questions, what it actually tells me is that the barriers to diverse participation in clinical trials is surmountable. You are talking about a population that is supposed to be resistant to engaging in science in this way, but they're gonna let you test your genome if you can tell them about their great-granddad. Okay, so we have access to these communities and to these populations, which is why I really appreciated when Dr. Gordon said, just give me a little more time for the education piece to get folks' curiosity and empathy up, and that is the key to engaging in the participation that we need to broaden this space. So when I think about how to wrap all of this together, I think about 5 things in this conversation that are really important to me about clinical diversity. And I'm really preaching to the choir now because I'm echoing things that you've already heard. So the first thing is that we do understand now that the incidences of particular diseases can vary significantly by race and ethnicity. That alone is why we need all hands on deck and all communities involved. Second, we also know that in concert with number 1, the safety and efficacy of given therapies can also vary widely based on gender, age, race, or ethnicity of the patient. And we want to know all of this. If I'm only supposed to take 3 aspirin, just tell me to take 3. Don't tell me 4 to 7 and let us know how it works. These are the kinds of things that we begin to understand when we're able to ask as many questions of as diverse a population as possible. So you've got 1 and you've got 2. We know that these factors that we as people bring into this research makes a difference. That leads into number 3, which is exciting for me because I now run a history museum, but I'm still a science nerd. Clinical trial diversity is growing in importance because the nature of science is changing. We are indeed on the cusp of personalized medicines, and it becomes a little less scary every day. And so when we talk about the personalization of medication and treatment, you're not just talking about efficacy, but you're also talking about trust. So imagine you've got a new experimental medication on board. It's looking really, really good. And then you want to say, but we're only going to try it on these people. Now, there was a time when that would not be the good thing to say, and it was what we were saying. But this is actually the power of science. This is actually the power of where we have begun to go. In order for our medications and our treatments to become more efficient, they are going to have to become more personalized and be for particular communities with particular backgrounds. And in order to do that, we've got to have trust. Trust comes from education, and it also comes from participation. Think about the number of times you've tried something new just because someone you trusted or looked like you told you it worked for them. So all of that wraps in together. So the 4th thing ties into that. I remember when I was in high school and we finally decoded the genome and we figured that was going to be it. We'd work with that one document for the rest of our lives. But very, very recently, just in the past months, we've now begin to understand the pan-genome. Listen, just let us scientists keep making up words, but trust me when I say that it means that we now even have a greater understanding of the genetic diversity within individuals and population. And all of this is feeding into these medicines, into these potential cures. And it means we need a broader base of this genetic diversity inside the clinical trials in order to activate the power of this. And last, but certainly not least, the true health equity is about access to care and treatment. And it's about equitable participation from the lab laptop to the pharmacy countertop. All the way. This is about our researchers and scientists. This is about our participants. This is also about our folks on the front lines who are actually talking about with their patients how to use these treatments. As we talk about this, we do need to have a very, very broad perspective to have better efficacy for a broader group of folks under a fuller range of participation. This is ultimately how we get the job done. And what we've discovered today, we're not talking about tomorrow. We're literally talking about it's happening right now. We're building the blocks, we're building the foundations, and actually the parade of elected officials that have come through also shows that we are having support at all of those levels. In April of 2022, the FDA proposed draft guidance for the industry about setting enrollment goals based on who is actually affected by disease. Imagine that. You want to have folks who are actually impacted, overrepresented in the trials that you're doing. In 2023, the omnibus spending package by Congress imposed statutory requirements for clinical trial diversity plans as the default, not the other way around. And this is important because it means we do actually have the marching orders. Starting in 2024, the FDA is directed to publish annually an aggregate report of these action plans, along with reasons trials are meeting or not meeting these goals so we can solve that solution. Because, of course, what gets measured gets done. And also, scientists love reports. So as we think about all of this, this is context and this is foundation as we circle back. Alzheimer's, glaucoma, macular degeneration. We're talking about three intersecting, interweaving diseases that have conditions across populations such that millions are affected. And so we can move beyond what I call the nudge through to the breakthrough if we think about being able to maximize the power of where science and medicine is going and combining that with an intentional and directed diversification of all who are involved, because we need all of that data to move us forward. In short, we're here. This is now. Breakthroughs are phenomenal, but they're not free. And so, as we head into this space, we're making some really tough decisions about what to do with our money and with our funding. Even one of our elected officials so wisely said today, this is a very strong return on investment. And many of those who care about these things, who are elected in this House, came simply because we asked them. And so if you want to know how we can all get involved and support, we should just ask. Let's keep it moving. Thank you.
Thank you, Tanya. I think our speakers today would agree on two absolutes. First, when it comes to the right level of federal research funding, the ayes don't have it. You're supposed to get that. We're in Congress. The ayes don't have it. Now is the time to fully fund federal research into the two preeminent causes of vision loss. No one wants to age and lose their sight. Second, the true health equity starting in the lab is a major challenge for all, and this has to be a priority. We need to shift that thinking about all of us. So let's be bold. Each and all of us, policymakers, thought leaders, influencers, scientists, funders, advocates, patient community. Let's be bold and commit to having a cure in mind for Alzheimer's and a cure in sight for glaucoma and age-related macular degeneration in our generation. Together, let's make Alzheimer's a memory. Let's commit to catching up by doubling federal research funding for both glaucoma and macular degeneration, as we have spent for others so relentlessly. Let's get rid of this one too. Let's be bold and call for a formal recognition of vision loss as a manifest in conditions like glaucoma and macular degeneration, as a modifiable risk for Alzheimer's and other dementias. Let's be bold and resolve here and now to relegate clinical trial inequities into the medical history books, so tomorrow's medical researchers can read about how it used to be, not realize how it is. Let us be bold in building the bravery of the community of Valdosta, testing new and more engaging recruitment approaches and community outreach that builds trust, removes barriers, and makes best practices out of those that work. Let's mount a bold, government-funded national public awareness campaign using appropriate role models, rebuilding trust, and educating more people about these diseases and about what clinical trials are, why they should enroll, and how. Let's be bold and commit to our underserved communities to strengthen provider partnerships that get these eyesight-robbing conditions diagnosed early so they can be treated with all that we have today and tested for what more we may have tomorrow, and provide that gateway to an earlier diagnosis of dementia. The numbers speak for themselves. Most of us know or love someone whose quality life has been profoundly impacted by one of these conditions. With more than 300 million people impacted worldwide and counting. Let's be bold for them, for ourselves, for our children and theirs. Many thanks for your attention. We'd be happy to take a couple of questions, and I thank you for your concentration and participation and listening to this important group of leaders. Thank you.